Your patient makes it to the ICU after their surgery. What are some post-operative complications that you're going to want to look out for? The four major body systems that you want to look out for are cardiovascular, pulmonary, renal, as well as hematological. Cardiovascularly, you want to assess preload, afterload rate, rhythm, and contractility to make sure that the patient isn't suffering from hypotension from any of those. Pulmonary-wise, you want to make sure the patient isn't developing acute respiratory distress syndrome, or ARDS, which can be from a variety of reasons post-surgical intervention. From a renal standpoint, these patients commonly get an AKI or an acute kidney injury from either acute tubular necrosis or just from being on bypass for a prolonged period of time. And then hematologically, you want to make sure that they don't have increased bleeding from things like incomplete reversal of heparin, thrombocytopenia, or DIC. When are you going to try and wean the patient from a ventilator? Most institutions will try and put the patients on a fast track to extubation, meaning that they'll extubate 2 to 6 hours post-op. Studies have shown that extubating patients younger than 75 years old between 1 to 6 hours post-op will reduce costs of about 25% without increasing any risks or complications to those patients. What criteria are you going to use to know when the patient is ready to be extubated? I'd like to make sure that their sedation and their paralysis has been reversed so that they're conscious and awake, and they're also taking in good vital capacities around 10 to 15 mLs per kilo with a low FiO2 and a good ABG. I'd also like to make sure they're hemodynamically stable and that their electrolytes and temperature are normal.